So
We are
shall
fine.
we begin? Okay, Ashdeep, please.
Yes, sir. We are
Type.
live.
Yes. Okay.
Sir, can you mute? Good afternoon, all. I welcome you all to this webinar on the occasion of World Heart Day. Hypertension is one of the leading risk factors for heart disease, and healthy food choices play a crucial role in controlling blood pressure and protecting our hearts. This webinar will provide valuable insights from leading experts on managing hypertension through healthy food choices and promoting heart health with evidence-based strategies. This webinar is organized by Department of Community and Family Medicine AIMS Gorakhpur in collaboration with the project Healthy Food for All, an initiative of AIMS Rishikesh and Global Health Advocacy Incubator. I now invite Dr. U. Venkatesh sir for the welcoming and opening remarks.
Good afternoon, everyone. On behalf of AIMS Gorakhpur, once again, I welcome. This webinar has been organized by Department of Community and Family Medicine in collaboration with AIMS Rishikesh. Today with us, we have our guest of honor, Dr. Om Prakash Bera, sir. Sir is Regional Advisor at the Global Health Advocacy Incubator. Welcome, sir. I also welcome our distinguished speakers. Dr. Jigal Kishore, sir, is a well-known public health expert and is a famous academician and public health expert. He is from Safdarjung Hospital. Sir is serving as a director professor there at Department of Community and Family Medicine. Then we have Dr. Prasanna Tirunarvakarasu, sir. Sir is additional professor at AIMS Jodhpur. Sir is well-known academicians. He is very good in epidemiology, especially the NCD. Welcome, sir. We have Dr. Gaurav Arora, sir. He is ex-consultant of Safdarjung. Currently, he is in New York. He is serving as a consultant there at Mount Sinai Health System, New York, US. He is currently also pursuing his fellowship there at in complex and higher risk interventional procedure there. We are delighted by your presence, sir. Welcome, sir. Then we have Dr. Ashutosh Tripathi, sir. Sir is a famous cardiologist in the city of Gorakhpur, and he is currently associated with AIMS Gorakhpur. Thank you once again, sir, for joining us. So, as all of you know, hypertension often called the silent killer, and it is the one of the leading cause of the heart disease, stroke, and premature death. And the WHO says 220 million people in India live with hypertension, and there is a small fraction of people, that is 1 in 5, actually have adequately controlled hypertension. So, addressing this challenge requires combination of policy analysis, the policy action, also the community-based strategies, and individual lifestyle changes also. So today webinar, we aim to bring together public health experts, clinicians, and policy leaders to discuss actionable strategies for hypertension prevention and control. Once again, I thank you all. I hope we will have good webinar today. Over to you, Dr. Varki.
Thank you, sir, for this wonderful opening remarks. For the inaugural remarks, I now request our esteemed guest of honor, Dr. Om Prakash Bera, sir, to share the inaugural remarks.
I think he got disconnected. I think we can begin with Jugal Kishore, sir. I think please welcome, sir, and start.
We now begin our webinar sessions. So I request all the speakers to stay till the end for the Q&A session. So I invite our first speaker, Dr. Jugal Kishore, sir, to speak on hypertension control in India, public health challenges and policy pathways. Sir, please.
Yeah, I would like to share my slides, although share. This is, I think. So, visual.
Yes, sir. Visible, sir. Sir, Dr. Bera, sir, are you there?
Yes, yes. Sorry, I'm in airport, so that's why like I'm having an unstable
Okay.
like
Okay.
connection.
Please
Yes, sir.
continue. Continue.
Yeah,
Yes, sir.
thank you, sir, so
So
much.
yeah,
And
I now request our esteemed guest of honor, Dr.
yeah,
Om Prakash
sorry for the
Bera, sir.
inconvenience. So
No, no, it's okay.
Yeah.
Continue.
Sir, please share your inaugural remarks.
yeah, yes, sir. Thank you. I think it's yeah, I think it's an honor for me to be in this stage along with like distinguished our teachers. Like I still remember my days like when uh, we used to read the National Health Programs book by Dr. Jogal Kishore, and that's like a fond remembrance. And I think like this is the in this World Heart Day we should like take a vow that we need to change something within the National Health Program so that the this year's World Heart Day theme of "Don't Miss a Beat" can actually be a reality. And means basically the theme emphasizes taking continuous and proactive steps to safeguard your heart health. And in the present situation, we are seeing a lot of like young adults facing like sudden issues related to cardiac and they anyhow like the entire family like misses them, and overall the entire heart health can be taken like care in a better way by a few steps in which I strongly like urge to cut down the screening age from 30 years of age to around 15 or 18 years of age, so that the young adults can be brought to the main segment of like screening and control. And overall, as an organization, as Global Health Advocacy Incubator, we always have advocated for strong guidelines which can be implemented on the ground and from which the impact can be driven out. And so with this remarks, I think like with the wonderful panel from India and from abroad, we are going to do means this will be like a knowledgeful like webinar. And moving forward, an impact should be a change in the guidelines of existing guidelines of the national program for NCD. So with this and like cutting down of all the like the side disturbances that is coming in from the airport, I now thank the AIMS Gorakhpur team, AIMS Rishikesh team for organizing this wonderful webinar and providing me a chance to speak on this. And thank you so much and best of luck to the organizing team and the speakers.
Thank you,
Thank you
sir.
so
Thank you
much.
for joining.
I now request Dr. Jugal Kishore, sir, to share his slides and start the session.
Yeah. It's visible now.
Yes, sir. Yes, sir.
And the second one also.
Yes, sir. Yes, sir.
Okay. So the topic given to me, I think we have discussed on hypertension and cardiovascular disease, and all the panelists or maybe say the speakers are expert more than me on cardiovascular problems, particularly hypertension. But my focus would be on epidemiological, challenges, the public health challenges, and what pathways forward we can look into. That would be my area of you know discussion. Now, when we talk about this prevalence rate of the hypertension, I remember when I was a student, it was started like, only just 5%, 10%. But now we have the meta-analysis and systematic review. It says that this is quite high. When you see number of studies over a period of time and a sample of say 21,000 and 7,000, it's a big studies. And in urban areas or rural area, then it is coming out to be more than 25%. So you can say that 1/4 of the total population is suffering from, hypertension. When we take a special group or or say the people who are above 40 years or 50 years, and the prevalence rate goes high. And that is why this is a really a big problem. And you rightly said that it's a silent killer, but it is budging your head all the time. This is another picture shows country-wise. That's a prevalence of hypertension by the control. And you just look at it that the India comes under this Southeast Asia region, and we can see it's a lower side. So we are not able to control our hypertension as other countries are doing. So that is also a big problem. The adult age group is 30 to 79 years. Country-wise, this pictures are indicating this one. And this is also another meta-analysis which shows hypertension control rate, which again says we have just around you can say 18 or not even reaching to 20% of the hypertension which is of a control. So this is a serious concern that we are not able to control the hypertension. So this one is Lassie study, wave 1 and 2017 to 18, which says again, if you have 100% of the cases, then only 72.5% are measured, and 57% are aware of that they are having hypertension. So it's a gap, in between what we able to detect, and the people are aware of what is going on in their, whether they have the hypertension or not, and then how many getting the treatment. So again, it's just 50%. So you can say that 50% is not at all you know uh, treated, and then ultimately just 27% is controlled. So it's a bad state. The rule of half is already known. But when we have the hypertension and not able to control, what problem can arise? So we have, cardiovascular complications where the heart attack, heart failures, and coronary artery disease, aneurysm, neurological complications like the stroke are quite high. Both ischemic and even hemorrhagic stroke are common in hypertensive patients. So the complication of vascular dementia, transient ischemic attack, then we have mild cognitive impairment also occur in them. Kidney problems also arise, leading to kidney damage and failure, worsening of kidney functioning. And then eye damage is also known, that is retinopathy, optic neuropathy, and other complications, which are again leading to so many other problems. Metabolic syndrome is one of that, sexual dysfunctions and hypertensive emergencies, which are again leading cause of death. So these are all complications if we are not able to, manage the hypertension properly. Now, when we come to the risk factors, I think again we have a study which is based on the National Family Health Survey, and similarly you can find large number of other studies. So we can directly see that how reason wise and occupation wise, education wise, and resident wise in male and female, you have the independent effect on the hypertension. So there are areas like in certain areas, in certain age group, you can find that they are having relationships. So uh, particular reasons could be because of their habits of the eating or lifestyle, which need to be, further in-depth studies are required. But that shows that we require, action in those areas, where we can say West, like we have the Rajasthan, and in case of the more than 30 years, then maybe I think East, Northeast, and West and South all have the problem. West, if you leave the West one. Employment, again, you can see the labor class in some less than 30 years, all the age group have the similar kind of problem individually. Education wise, higher education have a higher, risk factors. And then rural, urban, I've already said, but not much difference. But when we say the wealth index, then definitely the rich in a younger age group have a higher, chances, or maybe you can say the significantly related. Then the fuel, which again can be because of the rich, or the, you have the income, so you can definitely see the impact. So maybe BMI is, in all age group, as you become the overweight and obese, it is directly linked with your, hypertension. Tobacco use is also, and then alcohol use. So all are the risk factors which are, present. And diabetes and food diversity not found out, but maybe I think diabetes is in all age group again linked with. And COPD presence is also in certain age group has been found significantly related. So these are the, risk factors which uh, are, related to hypertension. In another studies, just to make it more concise way, many studies are showing that if we are higher age group, the odds ratio is quite high. BMI is also, related to, or say waist hip ratio, or say waist circumference, extra salt, alcohol, smoking, tobacco, this glucose intolerance, diabetes, and hypercholesterolemia. All are, more than, one odds ratio. So that is all about, risk factors. If you look at over a period of time, what is the status? So you'll find that continuously this undiagnosed uh, cases are going up, and the number of cases when we say the controlled and diagnosed but untreated, continuously you can see that in 1990 the control hypertension was less, but now it is much higher as compared to previously. So we are able to diagnose more now, but at the same time, this uncontrolled, or say this undiagnosed cases are continuously, troubling the community. So this is what we can see similarly world over. And when we see the Southeast Asia region, so the picture is almost same as what we can see. Differences are there in some countries, like, in Western world, or maybe the Asia, particular Asian, some of the Asian, Central Asian or European countries, where the difference are little, but the trends are same world over. And India is also not different from what we are observing world over. When we say projected trends, so in future, what is going to happen? So we have the risk factor, we have complication, and whether the hypertension is going to decrease or not. But we are seeing no, it's going to increase further. So in coming time, maybe I think more and more hypertensive will be there. So it's a big concern to us. That is why we have a national program for the prevention and control of NCD, and that was started almost decade early in 100 district. And I'm aware of since the beginning, how this program is running in the country. It was thought of that in 2017 we will be able to cover the whole country, but still there are, district where the progress is not very good. In some it is there. So strategies are simple. Public health strategy, you can say, focus is on healthy lifestyle through behavior change, which is the most difficult task, although this has been taken as number one. Another is the opportunistic screening, above 30 years. Now we should focus more on, the lowering down of the age, because we are able to screen large number of people, and this is successfully, going on. But the comprehensive examination and diagnosis management of the diabetes, cardiovascular disease, and stroke is not happening. But in tertiary care, yes, it's happening. But when we say the secondary and primary care, somewhere I think we are not able to examine all the cases and able to manage them properly. So that's a gap, and where we require more a kind of mechanism where the referral can be possible and all these things. Development of trained manpower. like we are thinking of even our ASHA workers and community health officers, they should be trained in at least in screening and able to, follow up them properly. So when we come to other, paramedical like the pharmacist, or maybe, we require more training in those areas like the nurses and the lab technician. Everybody should be trained. At least they themselves should look after their own health and the family. Then the strengthening of the tertiary care facility, which is area where some development has occurred. Private, yes, we have done a lot, but when we say the public health and health sector, uh, there are few development, and this is going well. Maybe I think more and more strengthening is required. And program management, as we have very good program management in TB, uh, and but similar kind of management, or say the National Health Mission, having a priority area in this area, I think can do much better when we say the program management. But anyway, these are the strategy which we think the program can manage very well and can do good things. So accordingly, these key interventions are the health promotion, where the public awareness through multimedia, counseling of health, healthy lifestyle, balanced diet, regular. So today topic is on diet and food. So this is the most important health promotion activity, where not only food, but we have to see that alcohol and tobacco are also stressed when we are talking on health promotion. Early diagnosis, screening, and then case management and capacity building of the where the infrastructure development, equipment, training of the human resource at all level, and NCD cell at the national, state, and district, where we have done it, but I think require manpower and also the functioning thing. Surveillance, monitoring, and evaluation, which is going in a peaceful manner, in a piecemeal manner, which require more comprehensive way of doing the surveillance of our these all the problems. Unfortunately, NCD is a very, very broad and linked with each other when we say not only just hypertension, but maybe I think we have to look into metabolic and the diet, and then salt, and then maybe your stress management, and then so many interlinked. So where we can understand this multifactorial causation of disease. There are many recent initiative under the program where COPD and kidney has been included, and they should be merged with the program of the hypertension and also the cardiovascular disease. Early detection of diabetes and hypertension, you know on the population basis, screening can be done. So that is also one area where we were doing only what the ASHA was able to do, or what the health center can, people are coming to them screen, but now more active surveillance is required and more screening is required in those areas. Integration of Ayush, and Ayush is also very important because they are running the clinics or running the centers, where if they are taking the screening, I think we can detect more and can put on medicine. Then pilot interventions of the control and prevention of rheumatic fever and rheumatic heart disease is still in some pockets and some areas is continue a problem. So how we can decrease this problem is also initiative. Integration of RNs, revise, or maybe this anti TB program, or say a national TB elimination program, merge with the NCD, where you can get the opportunity wherever the patient is coming. Can they be suffering from diabetes and hypertension? I think we can find, yes, large number of them are getting it. So why not, treat them together? So that's why, all opportunities should be, made available so we can get more and more patient and put on treatment. That is how we can increase the, control level or treatment level from 50% or 30% to maybe say 70 or 80%. The rule of half, uh, is taught to all the students and all the people, then they know that we have a lack of awareness and low diagnosis. So poor adherence, and we have to focus on these all issues. Okay, improvement of the awareness, adherence should improve, and inadequate supply of the drugs, and they should be made available. So challenges are limited access. Still, the health services in remote area and rural community where the problem is still high. It is not that the hypertension is not found in tribal areas or rural area. They are there, almost 20-30% of the population is suffering. So we require, their coverage. Workforce shortage in many of the area, trained manpower is not there. So we are able to provide through training or maybe recruiting. That's also a big challenge in front of us. Fragmented care is also a big issue. The continuum of care should have been there, where we are looking after each segment of the life in a proper manner. So if we can do otherwise, what is happening that it's a system problem where the hypertension will not be managed by the psychiatrist, or a psychiatrist, if he found the hypertension, he'll send to a cardiologist or to that kind of, sending for minor issues like the hypertension, which can be managed very well by, all the level. Why to be send and delay all the things? So such kind of, fragmented approach is very, very bad for health system. Then we have the socio-cultural behavioral factors where the food habit is a big issue, big problem. Some areas, salt intake is so high, they will not eat the food. Even, many of our houses, if they have developed the taste, they will not leave it. So changing their, food habit, unhealthy fat and sugar content, which is again a big problem in all the festivals. You'll find the people are carrying the sweets and bring it to the home. So once it's there in your home, you're bound to eat it. So changing such kind of, our cultural practices, our, habits. Physical inactivity has become a big issue, like sedentary lifestyle. It is our work and our development is making us to become more and more, sedentary. That's a big problem. How to reverse it back? We are from the rural to urban. We are moving whole the civilization to urbanized. So in urban area, people are becoming less and less active. That's a big problem. So in future, we are going to have such problem. Tobacco, alcohol, although tobacco is going down, but the alcohol is not going down. It is continuously high. So how to decrease? So we had a discussion on this, and we require legal and other on all the areas. Cultural belief, again that require the education and behavior change, where we think that it's a hypertension. Everybody is suffering from such kind of notion should not be there in the public, that it's not a serious disease and nothing happened. If you have a headache, you take the medicine of hypertension, and then you can leave it. Once it's going down, you just leave it. So that is where the compliance problem occur, and disturbance of the treatment occur. Economic and logistic barriers are there, out of pocket expenses. Drugs are becoming very highly costly, and then they live in between. So the poor people, due to financial burden, and once you have a complication, again a big problem. Supply chain inconsistency in, or say, availability of the drugs in all the centers. Sometimes we don't have a drugs which we were there before, and then even in our hospital we find that regular supply of the certain drugs are erratic and leading to such problems. So you can see that we have the evolution of this program, where we are reaching to change of name, integration of Ayush, and population-based screening. So over a period of time, we are improving. So coming time, should be more and more action. So what the policy pathways are? So we require decentralized and simplified care, like the task shifting and empowerment of the healthcare, centers, or or health and wellness centers, where the empowerment of the CHOs are required. They are the nurses. They should be given power to prescribe uh, medicine if it is in the initial phase. Their training is possible, protocol can be taught, and accordingly, like we are doing for the undergraduate student, similarly, these people can definitely manage at the local level. Similarly, availability of the medicine, and if it is look after in tertiary care, then follow up can be done at the community health, this health and wellness center by the CHO. So these all things, can further improve our treatment modality. ASHA workers and other, can be very good source of, adherence, which is, big problem in hypertension. So such kind of, like we have the TB, where some incentive can improve their compliance. Similarly, hypertension also require similar kind of, compliance. A regular follow-up is required. Fortnight, fortifying the supply chains, like the drug availability all the time. So how you can do, like we have the India Hypertensive Control Strategy, where the forecasting should be done, and how, drugs should be made available. So more and more AI and IT sectors should be involved in making available the drugs in a right quantity. More management people have to join into this. So this policy change is required, that, if we thought of program management unit to be part of it, then let it be, and they let them work, so they can have a better management of the logistics, also, availability of all the, supplies, and also surveillance method. Then procurement can become easy at the local level, particularly at district and sub-district level. Data actionable, like, use the data and seeing, whether we can use it for a local area. So, scoreboard should be read by our community health officers or health and wellness center. People should able to, see those all, parameters, and decide what next. So regular data review is required, that you are really doing good job or not, and where we are falling back. I was surprised in a ministry, report. Almost we have a screen, more than 100 crore. 100 crore screening is already done of the hypertension and diabetes. So you can say that almost, more than 60-70% of the population is screened. So like everybody is screened, which is not true. So how they are going to do it? So if the patient is coming in 1 month 2 times, or in a year, if he is coming 6 times, so it is counted as 6. So they, such kind of counting is going to create problem. So such kind of, duplication should be removed. Integration of AI, risk stratifications, like, who is at low, medium, and high risk. Automatically you start, their monitoring, and maybe, I think, reminding, and so the compliance can improve, and personalized interventions are required. And as we have started the preventive health and screening OPD, where the focus is on individualized, counseling, individualize their diet charting, and also treatment modality. So that's a way, I personally feel can be done in much better way. Supply and policy actions, like mandate AI-based clinical decision support system, definitely can be started, and we can train our workers for this. Fostering multi-sectoral collaboration, like the food safety, education department, urban department, they have to join together. Maybe, I think, the sports has to join together. Then only we can make a dent on the, our dietary factors. And multi-sectoral action plan is already there, but it's not, started. The action has not occurred on this. So the framework is planned, but, it has to be implemented in proper manner. It's only possible when we have a program, management system. intensify health promotion, address determinant like the campaign to generate more awareness about the disease, targeting the schools. And we should focus more on the school and colleges. We can, all medical colleges can take the schools, maybe 10 schools per advocacy is done. And this recommendation is sent to ministry also, that all medical colleges should be you know asked to take at least 10 schools and do the screening and education and everything. Taxation, like we have also said that more tax should be given, uh, to be put on the alcohol and sugar, sweeteners. Mass campaign is required for salt reduction and BP check. So way forward, these are all, I think the 5 areas are there. Community engagement, people have to be interacted with more problems, because it is suffering the community, and people are dying because of that. Information system should be, used in an actionable way using the NCD portal. Service system should improve, and financial, like, whatever is required through flexi fund in NHM should be given, and health system, should be made more suitable, accessible to, the patient. That's what I want to say. So if I've taken more time, I'm sorry, but that's all what I want to say. Thank you, sir.
Thank you, Dr. Jugal Kishore, sir. That was a very insightful session on the hypertension problem from a public health lens. So next I invite Dr. Gaurav Arora, sir, to speak on advances in cardiovascular care, integrating hypertension management with heart health.
Uh, yes, thank you. Thank you for inviting me. I was very much educated by the extensive talk by Dr. Jugal Kishore, sir. Thank you, sir. Thank you. I'll try to share my screen. So is my screen visible, sir?
Yes, sir. Yes, sir. It is seen.
Okay.
Yes, yes.
Yes. So thank you for this opportunity, to all the organizers, Dr. Behra, Dr. Jugal, Dr. Venkatesh. Thank you so much. So I'll talk on integrating hypertension management in heart health. So as Dr. Jugal Kishore sir mentioned that hypertension is a pandemic here, everywhere in the world. It is like 1 in 2 to 1 in 3 across the globe. And in Asians, it's almost 1 in 3, but almost 30 to 35% of the patients being hypertensive. So what is blood pressure? Blood pressure is the lateral wall, is the pressure exerted by the blood on the lateral wall of the arteries. It was not too way back in the past that blood pressure, higher the blood pressure was considered as more healthy a person is. In fact, the President Roosevelt and the in the time of World War II had the blood pressure about 250, and he was declared fighting fit for the leading the way US did in World War II. And then he died suddenly with the intracranial hemorrhage. And later, at the time of World War II, there were many studies that blood pressure was in fact responsible for his death. So there were many trials, many guidelines, many studies for him on in the last 50 to 70 years. And now we know that higher the blood pressure is uh, um, very harmful for us. So how to measure blood pressure? So the blood pressure hypertension management is a challenge, but the good thing is that we can monitor blood pressure. The individual can monitor his blood pressure at home, in clinic, and in office with the help of one device, a blood pressure monitor. And if one patient of blood pressure is trained how to measure his own blood pressure, he can measure it regularly throughout his life. it will be very helpful for him to maintain his blood pressure within normal range, and then he can be made free of the complication. See, the blood pressure arm should be measured only in the arm, not in the forearm, and he should be seated in a calm, composed manner, in a calm, with his hand rested on the table, and his blood pressure cuff should be at the heart level. There is a marker on the blood pressure cuff which indicates the position of the artery. It should be on the inner aspect of the arm, and both his feet should lie flat. He should not be watching TV or using his phone, and height of the desk should be appropriate for his rest. And then he should take 2 to 3 blood pressure readings at the gap of 1 to 2 minutes and take average of that. Similarly, we can measure the blood pressure in office or home if we can educate our patients and everybody around for the correct measurement of blood pressure. That's all we need to monitor and treat. So what the numbers mean? The upper number is the systolic blood pressure, lower number is the diastolic blood pressure, and the third one is the heart rate. So if when the patient is measuring the blood, write the date and the blood pressure readings, so that he has a record of his own readings, and it will be helpful for his own treatment. So normal, as we all know, is less than 120 systolic and less than 80 systolic. Now, the recent guidelines suggest that the more than 140 to 129 systolic blood pressure and about 80 diastolic blood pressure is considered elevated blood pressure, which may not require treatment, medical therapy now, but it is considered elevated. High blood pressure is 130 to 139 and diastolic 80 to 89. High blood pressure stage 2 is 140, more than 140 and more than 90. Hypertensive crisis is more than 180. So considering the initial stages like elevated more than 120 to 129, the lifestyle management is recommended first. In these patients, whether the patient actually has such high elevated blood pressures, or he is scared to visit a doctor, or he has some anxiousness or some other things which may be responsible for his white coat hypertension, there is ambulatory blood pressure measurement which can be done at home, which measures the blood pressure at about every 15 to 30 minutes throughout the day and 30 to 60 minutes throughout the night. For that, the reading should be 130 to more than 130 to 80 millimeters of mercury over 24 hours to declare hypertension, or 135, more than 135 by 85 millimeters of mercury for the daytime average, or more than 120 by 70 millimeters of mercury for the nighttime average. So ambulatory blood pressure monitoring is considered the best way to measure blood pressure in those who have borderline blood pressure, and to make a clinical diagnosis of hypertension. Or the other way is we can make use of blood pressure readings on multiple days, whether at home or at office. So this is regarding the higher limit of blood pressure. As we all know that blood pressure has a J curve, and below a certain limit, lowering of blood pressure also leads to harm. So below 110 millimeters of mercury systolic blood pressure, or below 70 millimeters of mercury diastolic blood pressure also is related to worse clinical heart cardiac outcomes. So preventing and management of blood pressure, we need to measure blood pressure, and as Dr. Mehra was suggesting, that the age of screening of the blood pressure for younger adults should be made to lower, as he was suggesting, to 15 to 20 years. Yes, that is recommended in the American guidelines for the recommendation for anyone who is more than 20 years of age should have a screening of blood pressure at least once every year. So this will be very helpful to catch younger patients early and to treat them at a younger age and make them free from the complications of hypertension. Yeah. So elevated blood pressure, as we all know, that this is very borderline situation. So we always start with the lifestyle management. The lifestyle management will be which will not include medical therapy. No pharmacological drug is there, but the patient is asked to exercise about 150 minutes per week or 75 minutes per week, vigorous intensity, or he should avoid sedentary lifestyle. He should do isometric resistance exercises, at least 1 to 2 minutes contraction, 3 sets grips like hand grips, plank, wall sits, or dynamic or isometric resistance training, or exercise. Regular prolonged exercise for prolonged periods has a role on reducing the blood pressure over long term. We will then in diet, low sodium, high potassium diet is recommended for to reduce blood pressure. Low sodium and increased potassium in the form of diet like coconut and banana, and or potassium fortified salts are seen to reduce blood pressure. Optimize weight management and diet, reduce table salt, reduce alcohol, and no smoking lead to reduction of blood pressure. So we'll talk on the diet part a little bit more later. So regarding the if the patient is diagnosed with 130 or more than 130 by 80, he should be in addition to lifestyle management, there may be some pharmacological drugs also be prescribed to him. And the patient should be made aware of the consequence of hypertension, because the hypertension by and large is an asymptomatic disease. The patient will not have any symptoms, and to motivate him to take medicine throughout for a long period of time will in an asymptomatic patient is sometimes difficult. And to convince that this treatment of hypertension will help him for the prevention of worse clinical outcomes like stroke, heart attack, heart failure, kidney disease, or sexual dysfunction are is important. So the risk coming to the risk factors of hypertension, we can treat the hypertension based on the clinical risk factors like the family history, increasing age, male gender, race, chronic kidney disease are the non-modifiable risk factors. And he should be motivated to work on modifiable risk factors like physical activity, unhealthy diet, being overweight or obese, too much alcohol, taking too much alcohol, or his cholesterol levels, high cholesterol levels, diabetes, smoking, tobacco, and stress can be managed to uh, prevent his the worst outcomes of hypertension. So regarding the lifestyle again, in no smoking, eating healthy diet, limiting salt intake, limiting alcohol intake, taking medicine properly, and regular physical activity, and maintaining a healthy weight in the long run have a key role in so regarding the main key interventions which is recommended is weight loss. Weight loss, if it is done, of weight loss will is expected to reduce the blood pressure by 1 millimeters of mercury. And in patients without hypertension, it reduces blood pressure. And there is a dietary approach to stop hypertension uh, is recommended for the is included of fruits, vegetables, whole grains, low-fat dairy products with reduced contents of saturated fats and reduced content of total fat is recommended to reduce the ill effects of hypertension by reducing blood pressure. Reduce intake of sodium to the optimal goal of less than 2300 milligrams per day, or ideal limit of less than 1500 milligrams per day is recommended. So uh, then enhanced intake of potassium, like aim for 3500 to 5000 milligrams of potassium per day, ideally by consumption of diet rich in potassium by coconut water or banana, or potassium fortified salts are recently available. Then reduced alcohol intake, ideally there should be complete abstinence of alcohol, uh, or the alcohol consumption for those who cannot stop because of medical reasons should be exercise, about 90 to 50 minutes aerobic exercise, or 90 to 50 minutes per week of dynamic resistance exercise, or 4 into 2 minutes of isometric resistance exercise have a huge role in reducing blood pressure over long term. Meditation and yoga also has a key role in reducing blood pressure. Trained by a professional, followed by 2 into 20-minute sessions per day while seated comfortably with eyes closed, can reduce blood pressure to about 5 to 7 millimeters of mercury uh, in follow-up. And breathing control exercises, slow breathing exercises, can reduce blood pressure by about 5 millimeters of mercury as well. So these are after the initial diagnosis of hypertension, the lifestyle and enforcing the lifestyle management, there are certain diagnostic tests one should undergo, which include the hemoglobin, the serum creatinine, lipid profile, fasting blood glucose, thyroid hormone, urine tests, and an EKG. These are some basic tests which every patient should undergo at the diagnosis of hypertension. Following which, if the blood pressure is not controlled with the lifestyle management after a follow-up of 3 to 6 months, the medical medicines are prescribed, which are mainly from the 4 first-line groups, which are ACE, or ARBs, and calcium channel blockers, diuretics, or beta blockers. So initially, usually two of the drugs are started with at lower doses in combination to reduce the ill effects of the side effects of the drugs and also have a better control for hypertension. The medicine should preferably be taken in night time so as to control the blood pressure more in the night in supine position. So combination medical therapy, two of the classes of the drugs are used as step one. Then if the blood pressure is not controlled within few weeks or months, then a third drug is added in the same pill combination. Then if the three drugs in optimal doses are not able to control hypertension, we call the patient as resistant hypertension, and then other classes of drugs like spironolactone, alpha blocker, or beta blockers are needed. And we should also look back whether the patient is compliant with the medicine, whether the patient is compliant with the lifestyle management, or there are something we can do in the lifestyle and the compliance part. Taking medicines regularly is important. Recently, there was a study which showed that um, about 50% of the patients, even in the large clinical registries or trials, were not compliant to medical therapy and lifestyle. So this is a huge gap which we can address by repeatedly motivating the patients about the impact of compliance and to medicine as well as the lifestyle, which are both required for a long-term blood pressure control. Again, blood pressure monitoring at home should be reinforced so that he should stay motivated and because to keep his blood pressure under control so that he can protect himself from the ill effects of hypertension in the long run. So what is the target range of blood pressure? When should we say the blood pressure is adequately controlled? Target range is as low as reasonably achievable. Systolic blood pressure target range is 120 to 129, which is class 1 by the recommendation. And target, if blood pressure is of 120 to 129 is not achievable because of side effects of medicine or because of orthostatic hypotension, in elderly or frailty, then less than 140 should at least be achieved. As we talked about resistant hypertension, we may need to add more than 3 drugs, which will require introduction of other classes of drugs like mineralocorticoid receptor antagonists or central alpha 2 agonists or alpha blockers in various combinations, according to the patient comorbid conditions and other medicines what he's taking. So when there is, so in the, we should always, there are certain reversible causes of hypertension or secondary causes of hypertension. And in certain group, people who have resistant hypertension, abrupt onset hypertension, or onset of hypertension at a young age of less than 30 years, exacerbation of previously controlled hypertension, disproportionate degree of hypertension, or malignant hypertension, diastolic hypertension, unprovoked sudden onset hypertension, or family history of a reversible cause of hypertension. We should look for various reversible causes of hypertension. And these are the secondary causes of hypertension, like obstructive sleep apnea. In large registries, it is seen to be present in 25 to 30% people. Chronic kidney disease is by far commonly found. Primary aldosteronism is a very undiagnosed underlying condition found in such patients. Drug or alcohol induced, so we should dig down in the drug-induced hypertension or alcohol, renovascular thyroid, and coarctation are other rare causes. Obstructive sleep apnea can be diagnosed at the bedside with the if the neck circumference in males is more than 16 inches, is suggestive of obstructive is indicative of obstructive sleep apnea. And weight loss and CPAP therapy, continuous high pressure airway pressure, breathing at home, can reduce blood pressure. Primary aldosteronism is commonly seen in patients with have low potassium in ports, and it can be treated with mineral receptor corticoid antagonists or may need surgery. Renovascular hypertension is seen in far fewer people with renal artery stenosis, which may need intervention or surgery. So other interventions which offer renal artery denervation or investigational interventions are under investigation are vagal nerve stimulation and baroreflex activation therapy, which are under investigation. Renal artery denervation are picking up recently for as an adjunct therapy for resistant hypertension, where the sympathetic nerves around the renal artery are ablated. This is done in patients who are, despite the maximum medical therapy, the patient's blood pressure is still not under control, or he is not able to tolerate the medical therapy. Then a radio frequency ablation catheter is used to ablate the sympathetic nerves, and it may lead to reduction in blood pressure in follow-up. So this is one study recently published in New England Journal of Medicine. It was a community-based intervention for managing hypertension in rural South Asia. As I was listening to Dr. Jugal Kishore, he mentioned that training of the ASHA workers, training of the community health workers, particularly in correct measuring of blood pressure, maintaining encouraging the patients to promote to lead a healthy lifestyle, and how to have a healthy diet, prescription of hypertensive therapy, risks of stratification of lipid lowering, taking down their lipid levels from time to time, identification of uncontrolled hypertension and high risk individuals in the community. So these 5 points were done by 3 monthly visits by the community health workers. They did a clustered sampling technique to sample various communities from the South Asia, from various countries, and where these community health workers participated to encourage people to follow a diet and lifestyle, and also the compliance and ensure the compliance to the medical therapy. The blood pressure control was far superior. And they also noted that there was a mortality reduction, which was not the key endpoint actually, but it was a this thing. So with that note, I end my talk, and I wish everybody a happy World Heart Day, and thank you.
Thank you, sir, for a wonderful, insightful session. So now I invite Dr. Ashutosh Tripathi, sir, to speak on hypertension and the heart, clinical insights for better patient outcomes. Dr. Ashutosh, sir, please.
Yeah, thank you. So, is my screen visible? Not that. Now, is it visible now, someone?
No, sir.
I don't see the screen. Oh, okay. Yeah, it has come now. You'll have to put the slideshow. Okay. Yeah. Okay. Good evening, Jugal Kishore, Dr. Gaurav. Thank you for a very insightful talk. So now this topic was given to me as hypertension in the heart with clinical insight for a better patient outcome. So it's very well known and introduced by the previous speakers, just modifying to it. So nothing much. So hypertension is a leading modifiable risk factor, as we all know, and it contributes mainly to the coronary artery disease, heart failure, all the spectrums, and sudden cardiac death. So early detection and targeted management improve long-term outcomes. So as sir has already emphasized on the need of training ASHA and healthcare workers at peripheral level, so that because this is mostly a disease which is not producing any symptoms, so by and large it goes unnoticed for a very long period of time. So mostly when the patients reach at a tertiary care center, they have developed some kind of associated diseases of the heart, which will be just describing in a short while. So this is a global epidemic. Hypertension has become a global epidemic, and India is contributing significantly, about 22.51%. So in some time, it will be like a leader and among the hypertension and diabetes. So now the Indian story is that nearly 30 to 40% of population in the urban areas and 12 to 17% in the rural areas are hit by the hypertension epidemic, out of which 23.5% and 22.60% are women, which are above 25 years. So what are the cardiovascular effects of the hypertension? So uncontrolled and prolonged elevations of BP may lead to a variety of changes in the myocardial structure, coronary vasculature, and conduction system of the heart. These changes can indeed turn to development of left ventricular hypertrophy, coronary artery disease, various conduction system disease, systolic and diastolic dysfunctions of the myocardium, and complications that manifest clinically as angina, myocardial infarction, cardiac arrhythmias, and congestive heart failure. So these are the target organs for the hypertension. It can cause in the brain, it can cause hemorrhagic stroke. In the eyes, it can cause retinopathy. In the vessels of the limbs, it can cause peripheral vascular disease. To the heart, it can cause LVH, congestive heart failure, and other coronary heart disease. And the kidneys, it can cause renal failure. So, so it's an overview. The cause of hypertensive heart disease is chronically elevated blood pressure. The cause of elevated blood pressures are very much diverse. So broadly classifying hypertension, we can classify it into essential or the primary and then the secondary. So essential hypertension accounts for the disease, which is like 90% of the cases, and there is no perfect cause that we can attribute to. And the secondary hypertension, as Dr. Gaurav has explained, well, this remaining 10% of the cases of blood pressure, usually the reversible causes, are attributed to the secondary hypertension. So why we are talking about blood pressure guidelines, target BP and elevated BPs? Because here we can very well see that, just a minute, that from 115 by 75 systolic BP to 175 by 105 BP, we see an increase in CV mortality by up to 8%, 8 times. So, and as the CV mortality and risk doubles with each 20 by 10 millimeter rise of blood pressure, we see this graph here. There's a significant rise of the CV mortality up to 8 times as the BP is increased from 115 systolic to 175 systolic. So what is the etiology is very complex, and there is a interplay of various things which causes this hypertension. This hemodynamic, structural, neuroendocrine, cellular, and molecular factors. These factors play integral role in the development of hypertension and its complications. So obesity has been linked to hypertension and LVH in various epidemiological studies. So 50% of the obese patients are having some degree of hypertension, and 60 to 70% of patients with hypertension being obese. So this is all a complex interplay and a vicious cycle between obesity and hypertension. So just out of the topic, so because of such a complex interplay between cardiovascular diseases, obesity, diabetes, hypertension, now we are coming up with a concept of a CKM syndrome. So this needs a various type of discussion skill still. So what are the complications in the cardiovascular system? It causes LVH. So the patterns of LVH, there are two patterns, concentric and eccentric LVH. So LVH plays a protective role in response since there is an increased stress to maintain a adequate. So blood has to be pumped to the blood vessels which are already constricted or against a very high pressure. So the walls of the heart gets too much hypertrophied. So these concentric and eccentric left ventricular hypertrophy comes into play so as to maintain the adequate cardiac output. LA abnormalities and other comorbidities. So what happens is since this blood has to be pumped against a high pressure, so there is a concentric thickening of the walls of the LV myocardium. So there is an increased LVEDP, and there is a since there is increased LVDP, so there is an increase in the LA afterload, which results in a LA and LA functional impairment with increased LA size. And now this LA size, when increased, the patient is getting predisposed to arrhythmias like AF. Also, any kind of such kind of dysfunction may cause rise in degree of the aortic regurgitation, and this aortic regurgitation causes the aortic root to dilate. So again, this sets a vicious cycle, and hypertension also accelerates the process of aortic sclerosis and causes mitral regurgitation. Coming to the third spectrum, heart failure. So hypertension is a cause of congestive heart failure, frequently under-recognized, partly because at the time of heart failure develops the dysfunctioning LV is unable to generate a high BP, thus obscuring the heart failure's etiology. So patient is presented with heart failure, but underlying causes high blood pressure, which is compensated because of the low status, cardiac output status at the time of presentation of heart failure. So the prevalence may be up to 33% and chronically elevated afterload, and the resulting LVH may adversely affect the active early relaxation phase and late compliance phase of the ventricular diastole. How comes comes to the spectrum comes the diastolic dysfunction. So diastolic dysfunction is common in patients with hypertension. It is accompanied by LVH. Other factors which can cause diastolic dysfunction is the coexistent CAD, aging, systolic dysfunction, and structural abnormalities such as fibrosis and LVH. So the next spectrum comes with the systolic dysfunction and decompensation. So in the face of elevated BP, LV cavity dilates to increase the cardiac output as LVH fails to compensate. As the disease enters the end stage, LV systolic function decreases further. So there is an activation of the neurohormonal and the renin-angiotensin pathway. So which results in a salt and water retention and increased peripheral vascular constriction, leading to progressive symptomatic systolic dysfunction. Coming next is myocardial ischemia. So how hypertension causes myocardial ischemia? So there are two reasons to it. So increased afterload secondary to hypertension leads to increase in LV wall tension and transmural pressure, compromising the coronary blood flow during diastole. The other point is the dysfunctional microvasculature beyond the epicardial coronaries may be unable to compensate for the increased metabolic. The myocardium gets thickened and stiffened so that the most peripheral part of it fails to get perfusion from the normal circulation. Hence, it gets ischemic. Now, coming to arrhythmias, as already explained, the most common is the atrial fibrillation, then PVCs and the ventricular tachycardias. Most of them can be attributed to the AF causative agent can be attributed to enlarged LA size, and other etiologies can be attributed to getting LVH, and then even the myocardial ischemia that is happening at a peripheral level can induce some kind of focus of origin of PVCs and ventricular tachycardias. So now that we have known all these complications and we know that we have to identify the patient, so what do we do now? So how to assess a patient? So take a basic history, physical examination, some basic lab tests like creatinine, eGFR, potassium, sodium, LDL cholesterols, and other investigations like a 12-lead ECG. Extension to it, we can go to finding out the target organ, we can add it to with a echocardiography, coronary calcium scoring, MRI. For kidneys, we can do an ultrasound and Doppler. For carotid, we can do carotid Doppler. For measuring the stiffness of the arterial wall, we can use pulse wave velocity and ankle brachial index. For brain, we can screen out using a CT or a MRI and a cognitive function test. For retinopathy, we can do a fundoscopy. Then when to refer a patient? So as sir has already explained, we should train the basic health workers and doctors at primary level to identify and treat and mitigate the process of hypertension as soon as identified. But at a certain stage, that sometimes it happens that the blood pressure is not controlled, and the patient soon starts deterioration in the form of getting heart failure or deteriorating kidney functions. BP remains uncontrolled over 2 or 3 medications. At that time, the patient has to be referred to a specialist. Went to a hospital. So in case of hypertensive urgency or emergency or anything related to it, the patients then can be referred to a hospital. So how to diagnose the blood pressure? In guidelines nowadays, all the 3 are included: in office and out of office. So in office BP measurement of systolic BP more than 140 and diastolic equal to more than 90 is considered to be hypertensive range. Home BP monitoring says a systolic BP of more than 135 systolic and diastolic more than 85, suggestive of hypertensive category. And ambulatory BP monitoring, so 24-hour mean blood pressure, which shows a systolic blood pressure of 130, more than 130, and diastolic more than 180, with a daytime average of systolic BP more than 135 and diastolic more than 85, and nighttime of more than 120 and diastolic BP of more than 70, more than equal to 70, is considered to be hypertensive. Second in the line, we should search for the target organ damage. As we have already explained in this slide, previously said that we can extend our examination to these organs in particular to find out the target organ damage if there is any. Next, during basic examination, we can conclude whether it's essential or primary or secondary hypertension. So historical clues to secondary hypertension, that those are the treatable causes. So that should be definitely looked for. The historical clues can be resistance to more than 4 drug therapy, young age of onset, sudden increase in BP, episodes of extreme BP, low potassium and muscle cramp, women between the age of 35 to 55 and new onset with daytime sleepiness, snoring, poor sleep habits. Physical examination can suggest of abdominal bruit and reduced peripheral pulses, femoral bruit, renal bruit, unequal BP in extremities, reduced pulse in extremities, severe lower limb edema, wide pulse pressure, buffalo humps, central obesity, and enlarged thyroid. Now that we have identified the target organs and we have seen the BP in our diagnostic way that we have classified the patient, the further classification depends on the staging of the patient. Here stage 1, 2, and 3 are the classification given. Then we have to find out the target organs which are also involved, according to which we suggest that whether 1 or 2 risk factors or more than 3 risk factors, and or inclusion of CKD and diabetes, and established CVD or CKD more than grade 4, according to which we have classified the patient into high normal, grade 1 hypertension, grade 2 hypertension, and grade 3 hypertension. These are the increasing risk of severity as discussed. So now we have distributed, now we have diagnosed the patient, examined the patient, classified the patient. Now we should target the medications. So why we should target the medications? Because here we have seen that a meta-analysis of 61 prospective observation trials in 1 million adults for 12.7 million persons years, just a 2 millimeter decrease in systolic BP has reduced 7% reduction in the ischemic heart disease and mortality, and 10% reduction in the risk of stroke and mortality. With the antihypertensive control, there is a further MACE reduction. MACE includes CHF, stroke, CVD deaths, and CHD events, all included in MACE. We see a significant fall in the MACE events with the antihypertensive drug therapy. So what are the treatment goals? So now the treatment goals should be, we should target the BP of 140 millimeter by 90 millimeter in patients with uncomplicated hypertension, 130 and 85 of patients with renal disease with less than 1 gram per 24-hour proteinuria, and less than 125 by 70 in 75 in patients with renal disease and more than 1 gram of proteinuria. So now we have to select the intervention, what we want to give to the patient. So according to which we can give, like we can modify the diet, we can give advice on physical activity, weight reduction, reduce sodium, and augment the potassium intake and limit the alcohol intake, for which separate guidelines are already prescribed. So starting with it, for the lifestyle modification, we have to ask the patient to lose weight if the patient is overweight or obese, and then limit alcohol intake to no more than ethanol of 100 proof per day, or 0.5 ethanol per day for women and people of lighter weight. Increase aerobic activity nearly 30 to 45 minutes in 5 days in a week. Reduce sodium intake to no more than 100 millimoles, that is equivalent to 2.4 gram of sodium. Maintain adequate intake of dietary potassium, nearly 90 millimoles. Maintain adequate intake of calcium and magnesium, and stop smoking. How does this help? So weight reduction causes approximate BP reduction of 5 to 20 millimeter of mercury. DASH diet, which is rich of fruit, whole grains, causes an approximate BP reduction of about 8 to 14 millimeter. Physical activity enhances further fall of BP to 4 to 9 millimeter of mercury. Sodium reduction causes a fall in BP of 2 to 8 millimeter of systolic, and moderate amount of alcohol moderation can cause 2 to 4 millimeter reduction in the systolic BP. So lifestyle treatment includes FIT strategy. FIT is frequency, which is 4 or more days per week. Intensity is moderate. Time is 30 to 60 minutes, whatever is feasible. And type is dynamic exercise like walking, jogging, cycling, and non-competitive swimming. So FIT strategy should be prescribed for lifestyle modification. Then DASH diet. DASH diet is significantly lower the BP 8 to 14 millimeter in patients with hypertension. DASH diet is rich in important nutrients and fiber. DASH diet includes food with more potassium, calcium, magnesium, and are found in average American diet. This diet should be advised in patients with hypertension. So coming to the pharmacotherapy, so we have to consider giving prescription to patients with medicines with average diastolic BP equal or more than 90 millimeter of diastolic BP, with target organ damage, with elevated systolic BP, with habits of cigarette smoking, abnormal lipid profile, strong family history, truncal obesity, and sedentary lifestyle. And the initial choice of therapy can be in, So the pharmacotherapy can be initiated with ACE ARBs, then the calcium channel blockers, then beta blockers. For the JNC7, this is the JNC7 algorithm for the treatment of hypertension. So initial drug of choice with, there are 2 branches from it. No compelling indications and compelling indications. Compelling indications we have seen, or of CKD, albuminuria, and target organ damage, for which we can advise drugs with compelling indication and BP medications as needed. For with non-compelling indication, for stage 1, we can use diuretics for most considered ACE, ARBs, beta blockers, and calcium channel blockers. Stage 2, blood pressure more than 160 by more than 100 diastolic. 2 drug combinations for most, diuretic plus ACE or ARBs, or beta blockers or calcium channel blockers. So if the goal is not reached, then we have to optimize and again change the strategy of adding one more therapy to the existing therapy. So it's a very common question when to start with a single drug and when to start with a double drug therapy. So single drug therapy is usually given when the target systolic BP is if your target is the target and the patient's target is the difference of more than 20 and by 10 is systolic. If it is more than 20 by 10, then you have to start with a dual combination therapy. Again, this is the same therapy, and then I'll just skip this out as I'll be falling short of time. Yeah. So this is a modification, or this is taken from the European Society of Hypertension Guidelines 2024. So we can use a step one. At step one, we can put a dual combination. Then at step two, we can increase if the BP is not achieved and well controlled. We can introduce a one more therapy, and then step three. This can be a true resistant hypertension where we can plan to add other therapies also. So here again we have to initiate and evaluate the patient after giving a therapy. After initiation of the therapy, we have to evaluate the response at every 1 to 2 visit, office blood pressure and home blood pressure with a selected lab test, target organ damage, the lifestyle and the dietary intervention observed, how the patient is very well adhering to the therapy that is discussed with him, and supports of the individual needs and shared decision making. The short-term follow-up for 3 to 1 year, and then long-term follow-up for more than 1 year for maintaining an optimal BP control. Other than that, there are some other agents also to control blood pressure. These are usually used in the hypertensive emergencies and urgencies. These are usually the IV drugs like hydralazine, enalapril, beta blockers, other things. So coming to, as we have seen, there are various spectrums of this hypertension that affects the heart. In short, I'll be telling you how to treat each of them. So treatment of the LVH. So treatment of LVH doesn't, there are a number of studies which show that regression of LVH do not cause any much benefit. So, but this just shows the control of the blood pressure. Moreover, the best drug which can be used to cause a regression in this LVH is ACE inhibitors and ARBs. So this is what is shown here. So how to reduce the diastolic dysfunction? So ACE inhibitors again, then the beta blockers and non-dihydropyridine calcium channel blockers have been shown to improve echocardiographic parameters in the symptomatic and asymptomatic diastolic dysfunction. Addition to it, we can use diuretics also, and then very recently SGLT2 I think is the second drug of choice. Then LV systolic dysfunction, diuretics, predominantly loop diuretics, as the use for the treatment of LV systolic dysfunction. Low dose spironolactone has shown to decrease the rate of morbidity and mortality in patients with NYHA class 3-4 heart failure. ACE inhibitors again, then beta blockers, and trial have shown improvement in outcomes in patients with NIHA class 4 heart failure with carvedilol administration. So these drugs should be started when the patient has no signs of fluid overload and is in the compensated heart failure phase. So this is just shown how to introduce. Then arrhythmias. The treatment of this condition depends mainly on the specific arrhythmia that is caused. In our case, this causes mostly AF. So anticoagulation should be administered to these patients. In addition, treatment of anxiety, stress, sleep apnea, treat and contributing to precipitating factors. So these are the other comorbidities which causes hypertension needs to be treated with CAD. We have to use beta blockers and ACE inhibitors, and then long-acting CCBs and dihydropyridine CCBs. For stroke and TIAs, we should prefer using ACE inhibitor with diuresis. Now, these are the recommendations and these are the guidelines summary. From 2017 up to 2017, and in between 2017 to 2025 there were multiple guidelines, but recently this paper was published in ACC, Journal of American College of Cardiology, and this has tried to summarize down the recommendations from 2017 to 2025. So in short, I will tell here that on the broad basis, this was this year in 2017, according to the old recommendations, there was a primary prevention of CVD with no CVD, and ASCVD risk calculator was used to identify patients with ASCVD risk of less than 10, and BP was managed accordingly. Here, these ASCVD risk has been replaced by the Prevent Heart score. So how Prevent Heart score is better than ASCVD heart risk score is that we consider using UACR, HbA1c, and other risk factors also while we are calculating the while we are using the Prevent Heart score. So, and microalbuminuria and UACR, which are interrelated and entirely dependent on each other. So UACR and microalbuminuria has been found to be in various studies, it has been found to be very closely related to the CVD mortality. Hence, Prevent score is better using nowadays, better than ASCVD risk score, which were used previously in the other guidelines. Coming to the weight loss part, so weight loss before in nearly till 2017 and later guidelines, there was no target set. But now in 2025, the recent guidelines says that the weight reduction of at least 5% in the first month and up to additional 5 to 10 kgs in the next 6 months is advised by the Endocrine Society as well as the Cardiovascular Society for reduction of blood pressure. Coming to the DASH diet, again, it remains the same. Then for sodium reduction, there was no dietary goals set earlier in the earlier guidelines, but now the guidelines have been set to that sodium reduction of less than 2,300 milligram per day, further going down up to 1,500 milligram per day. These are the recommendations for sodium. For potassium, earlier there was just like potassium supplementation, which is currently being continued, and avoidance in the CKD patients. Now, earlier it was given as a recommendation level of class 1 indication. Now it is given as a class 2 indication. Just summing up, there was no recommendation on yoga and other exercise enabled BP reduction program in the last guidelines. Basically yoga, there was no comment about stress reduction and yoga, but now class 2B indications have been given by the ACC and AHA guidelines for yoga and stress management programs. So for take home message from my side is, before initiating any patients with medications for high blood pressure in stage 1, we should calculate the Prevent Heart score. And for a low Prevent Heart score less than 7.5, we should initiate an average BP of 130 to 39 with 80 to 89 millimeter of diastolic BP. We should first introduce lifestyle intervention for 3 to 6 months, and then only we should, if the targets are not reached, only then we should prescribe the medicines to the patient. So this was the master ESH master plan for hypertension management. So M stands for measure the BP and diagnose it. A stands for assess the patient. S and T is for select the therapy, that is the lifestyle intervention, drugs or whatever. And then we have to evaluate the response with blood pressure, proper blood pressure management, and other biochemical parameters to see how the response is going on. So with that, I'll end up my session. Thank you very much.
Thank you, sir. That was again an insightful session. Now, our final session will be delivered by Dr. Prasanna, sir, on food as medicine, dietary strategies for hypertension prevention. Prasanna, sir, kindly share your slides.
Yeah. Thanks.
I'm sorry. I mean, just give me one moment.
Yes, sir.
It's not getting shared.
Yes, sir. Now it is seen.
I think I'm sharing it as a screen because the slides are not getting shared.
Okay, sir.
Is that fine now?
Yes, sir. Yes, sir.
Okay. Good evening all, and thanks to Dr. Venkatesh for the opportunity to talk on dietary strategies today as part of World Health Day. And thanks to all my earlier speakers who have given a very good gist and as well as the context for what I'm trying to talk. I'll try to keep it very short and simple, and also take into consideration the wide audience. I mean, with starting from medical officers till, I mean, senior professors in public health and community medicine. I mean, I'll just quickly run you through some of these as concerns which we should have in mind while we are planning for dietary strategies for prevention of hypertension. Right. I mean, so when we are talking about the non-communicable disease prevention, I mean, we talk about these four common four risk factors, where unhealthy eating is one of the important risk factor. So trying to address, and WHO recommends that, I mean, when we are trying to talk about addressing or preventing non-communicable diseases, we need to do an integrated approach using all the four important risk factors. I mean, it's not a standalone. So that's a basic point we need to have. And a very important slide which has been shown earlier by the previous speakers as well. I mean, I'm trying to put only the dietary related aspects of these interventions, which have shown we have evidence in reduction of blood pressure, systolic blood pressure, both among normal individuals and those with hypertension. So weight loss, I mean, following a heart healthy diet, like something like a DASH diet, a reduction of intake of sodium, as well as use of salt substitutes, enhanced intake of potassium, reduce alcohol intake. These are possible dietary strategies which do bring about, I mean, decrease in the systolic population, I mean, blood pressure, both at the individual level as well as at the population level, right? And you can clearly see the, I mean, reduction numbers on the left-hand side, these various numbers. Okay. So when we're talking about dietary interventions, especially in the context of India, I mean, one of the important challenges are major cultural significance of diet across the Indian subcontinent and the various variations in the dietary pattern and the constituents of the diet that are kind of puts us at certain, I mean, challenge. Also, I mean, when we try looking at some evidence-based strategies for the population strategies, we need to look into food, I mean, diet at three important categories. One is home cooked food, and food which is had outside the home, and also the processed and the packaged foods. And WHO Global Action Plan for Prevention and Control of NCDs, I mean, put forth 9 voluntary targets. And one of that important being, I mean, 30% relative reduction in the mean population intake of salt or sodium. And India was one of the, I mean, first countries to adapt this WHO's Global Action Plan and put forth its own targets with adding one more target. But I mean, the things remain relevant. So the target 5 is 30% relative reduction in the mean population intake of salt or sodium. Target 2 talks about 30% relative reduction in the prevalence of current tobacco use. And the target 4 talks about a 10% relative reduction in alcohol use. All of these, I mean, can be considered in the broader ambit of dietary strategies which need to be included. Salt being one of the important risk factor as well as among the dietary strategies, I have kind of taken salt as an, I mean, example here for the remainder of the discussion. So when I try looking at the amount of salt which average Indian adult consumes, I mean, various studies say that, I mean, Indian adults take between 8 to 11 grams of salt per day, which is approximately twice the recommended intake of less than 5 gram per day per person, right? And so higher salt intake is consistently shown to have higher risk of stroke as well as stroke deaths in various studies. And also literature clearly indicates that reducing the salt intake reduces not only the incidence of cardiovascular diseases by 30%, but also the mortality by 20% when they are followed up for a period of 10 to 15 years of follow-up. That's the Rose incubation period, which we often study in non-communicable diseases. Okay. So, but then when we talk about the salt intake, quite often we tend to talk about the processed food and other important things. But when we look at the Indian, literature, it clearly says that 90% of daily salt intake happens through foods prepared at home. And most of these salt, addition happens either during cooking or at the table. About 85%. So any strategy which needs to look at addressing the salt should have to look at these two important aspects about the home cooked food and about the addition of salt at the cooking and at the table. So any strategy needs to train these individuals at these points. So again, similar to the previous broad one, there are three major sources of dietary sodium or salt. The one which is added to the food at cooking or at while eating at home. Those added in the foods prepared outside of the home, either restaurant food or street food, or food provided at school and other government institutions. And the third variety is added in the processed and packaged food, which the other developed countries do concentrate about. But yes, it's also important in India. But at the same time, we should not be forgetting about the other two categories as well. So one important strategy which various documents put forth is replacing salt with a low sodium salt. So there are quite a lot of evidence, and there are a bit of risk about it, but largely, the benefits outweigh the risk. But challenges to implementing this low sodium salt strategy in India is limited availability, low awareness, high prices, concerns about taste, low demand, and high cost, and all that are definitely concerns. It's not very popularly known as well as popularly available. Okay. But one of the important point about this particular strategy is, this has a potential to reduce salt intake even in the absence of a major shift in the consumer behavior, even without trying to talk about the addition of salt. If we can overall, change the salt in the ecosystem into low sodium alternatives, it's going to definitely have a significant impact. Also, WHO way back in the year 2013 came out with two documents, and one of these documents is about potassium intake for adults. So WHO recommends increase in potassium intake from food to reduce blood pressure, risk of CVDs and stroke and coronary artery disease in adults, which is a strong recommendation, and also suggests that a potassium intake of at least 3.5 grams per day for adults. And there are various food items which are also indicated in the guideline, including the beans, peas, nuts, green vegetables, root vegetables, and others which have appropriate potassium content, which can be included in the diet, to have added advantage. Okay. So when we plan for, salt intake reduction, there are, the question between should we use a multifaceted strategy or a single intervention? Clearly the multifaceted strategies, have proven to be more effective in terms of reduction in salt intake up to 4 grams per day. Whereas single interventions, lead to only less than 1 or about 1.5 milligrams, grams per day, depending on the strategy. So, we should always be going for multifaceted strategy rather than a single intervention. Okay, at the clinical level, there are also quite a lot of clinicians and medical officers and young clinical students here. At the patient level or at the risk counseling level, trying to use a 5A framework using small steps approach by trying to assess, advise, agree, assist, arrange, and not trying to overwhelm the individual with various information may help in trying to address the salt intake. There are, this very, well-known HEARTS package also has a booklet for healthy lifestyle counseling, which also has a page which talks about how to use 5A approach for fruits and vegetables and salt. Also, while we are trying to assess the salt intake among the individuals, we need to definitely be not asking just about one question, how much salt do you take or what are the salt? And there are three components at least you should be covering. One is the pattern of usage in terms of what salt or salty sauces they add, what seasoning sauces, I mean, what processed food high in, and all that needs to be asked. The second is their intention about, I mean, how much salt or salt they think they are consuming and how important to them is lowering the salt in the diet. Both of these are very important. And the third component, I mean, we also have to be knowing if do they have any, I mean, working control strategy like limiting consumption or looking at low sodium alternatives or using spices or avoiding eating food outside or anything specific they are particularly doing or interested in doing. So all these three components, I mean, will help us in effectively counseling a person who wants to address the diet. And while we are looking at the population level reduction of, blood pressure, there are various things we'll be need to be working on, including the food reformulation, trying to address certain things at the economic levers level, including taxes and subsidies, trying to work on the food labelings, including the front of package warning labels, and also trying to utilize strategies which address access and availability of various healthy food alternatives, including fruits and vegetables and those foods which are rich in potassium, and also trying to address the supportive settings, and trying to set standards for public institutions involved both in the production of food as well as various other things. So all of these definitely will have a synergistic effect towards addressing the mean population blood pressure as well as the mean population salt intake. So, this is what I've been trying to tell in the previous one. And there are also a few emerging dietary strategies in the literature as well. I mean, one, which is mentioned is trying to work at the level of gut microbiome. I mean, it is indicated that high dietary fiber and polyphenols promote beneficial gut microbiota, which produce metabolites that can lower BP. There have been a couple of studies and people are working on it. There are also another thing is personalized nutrition, which is coming up in large way in various fields. Trying to identify those genetic variations in taste receptors and ROS components, and trying to identify individuals sensitive to salt or other dietary factors, and trying to provide, tailored intervention while we are adapting some dietary strategy approaches are also being considered as some of the new strategies to address this thing. So these are some of the important points which I thought I should be highlighting. And these are some of the pictures from the Eat Right India, which uses a 21 days challenge, and for 7 days, they also talk about how to address salt. Thank you. Over to Dr. Venkatesh and team.
Thank you, sir. It was a wonderful, again, insightful session. Now we'll quickly go into the audience Q&A session. So I think from chat box, we'll take up some questions. So the first question is to Dr. Gaurav, sir. Sir, are you there? Gaurav, sir.
So not there. If not there, maybe I can take the question. There is no problem.
Oh, okay. So they are asking, from your perspective, which lifestyle intervention tends to show the fastest or most sustainable impact in your patients? And how do you motivate adherence in busy outpatient setting?
So basically, the lifestyle changes like reduction in salt intake and weight loss, I think is the most important factor, which we have seen to cause a lots of dramatic improvement. Even I have seen patients who are given 4 to 5 antihypertensive classes of drugs coming down to just one or even zero. So I would suggest this as the major game changer on the number of antihypertensives a patient is using, and see if the patient is getting benefited out of it. He sees that his medicines is going down. That itself is a big booster for him to further continue with the lifestyle therapy that he's already going on.
Sir, Gaurav, sir, you want to add anything which is most impactful fastest way intervention, lifestyle intervention, which you have seen in your patients, which has proven to be effective?
So why? So I think weight loss is the most impactful if there is scope for weight loss. Regular physical activity, 15 to 30 minutes per day, cutting down on carbohydrates, eating more fruits and vegetables, small changes in diet, and targeting weight loss for about 1 to 2 kg per month. Going a long way, and targeting to 10 to 12 kg per year, and from there on, it really motivates, because they can check their weight being reduced, they feel healthier, and their blood pressure is also improving. So that, I think, is the most effective way to put diet and exercise both together, and motivate them for weight loss, and they feel good, look good, and their blood pressure, hypertension, and other comorbidities like diabetes, heart health, everything improves with weight loss. Yeah. So that is the way I do it. Yes.
Next question, I think, is for Dr. Prasanna sir. So the question is, many interventions work well in trials, but face drop off in real world adoption. What strategies can bridge this evidence practice gap for dietary hypertension prevention? Prasanna sir?
Yes, I mean, thank you. I mean, it's an important question. Yes, I mean, any public health intervention or a preventive intervention, when we look, I mean, trial versus real world gap definitely exists. I mean, one of the important points which we need to consider is, I mean, in the trial, there are, I mean, capacities built around each and every aspect of the intervention. I mean, there is a person who's trained, there is a specific person, available to provide that particular intervention. But when it is transferred from the control setting to the actual real world setting, I mean, the lack of manpower, the lack of capacity, the lack of, protocols for effective implementation of that intervention definitely, I mean, may lead to derailing of the intervention, which has been proven to be effective in the trial setting, right? So when we are trying to shift, I mean, the intervention from the control setting to the real world, we definitely need to work on these aspects prior to the implementation of the interventions.
Okay, sir. Thank you so much, sir. Now I think we can conclude the Q&A session. So I once again invite Dr. U. Venkatesh, sir, to share the closing remarks and the way forward.
Thank you, Dr. Vaki. Thank you so much. And the hypertension requires collective action from communities, clinicians, and researchers and the policymakers. And we hope that today deliberation have inspired new ideas and collaboration to advance this goal. With this, first and foremost, I like to express my deep gratitude to Major General Dr. Vibha Dutta ma'am, our Executive Director and CEO AIMS Gorakhpur, for her constant guidance and encouragement. I like to extend my sincere thanks to our department HOD, although he unable to join today because of his travel. I also extend our heartfelt thanks to our guest of honor, Dr. Om Prakash Bera sir, for joining us for a short time. I sincerely thank our distinguished speakers for enriching session. Dr. Jugal Kishore sir, he provided some of the comprehensive and even some of the strategies, community-based strategies. I thank Dr. Gaurav Arora sir for his clinically grounded session on hypertension and also touching upon some of the community-based strategies. And thank you so much, Dr. Ashutosh Tripathi sir, for your clinical insights, especially focusing on hypertension and heart disease. And once again, I thank Prasanna sir for his valuable guidance on dietary strategies and prevention approach. Sir, it was very interesting session. Each of you brought a unique lens to the critical issue, and we are grateful for your time and contribution. I take this opportunity also thank Dr. Pradeep Agrawal sir for his project Healthy Food for All from AIMS Rishikesh, and also the Global Health Advocacy Incubator for the support in the organizing this webinar. A special thanks to our moderator, Dr. Varki, project scientist, for effectively moderating today's session. And finally, I thank all the participants across the country for your presence. Thank you so much. And thank you once again. We look forward you to continue support in future initiatives of AIMS Gorakhpur. Thank you so much.
Thank you, sir, for the wonderful closing remarks. So with this, we would like to end this webinar. So I request the participants to fill the post-test form to receive their certificates. And I would like to once again thank all our speakers and participants for joining us this webinar. Thank you.
Thank you.
Yes, and we will be sharing the YouTube link, and this entire webinar will be in the YouTube, and I will be sharing the link, and people can, those who missed today's session, they can rewind and review this session later. Thank you so much.
Thank you all. Thank you.
Thank you.
Thank you, everyone. Thank you.